Everybody. I'm going to talk to you about neural therapy and the Frankenstein conundrum. A warning in advance, this will be a bit irritating and it talks on sensitive topics, including some of the shortcomings we have in modern medicine, all with an intention to help treat and make patients better. 1818 was a year that Mary Shelley brought us a novel, Frankenstein, the modern Prometheus, in which a doctor stitches together body parts, electrocutes it, and brings it to life. This new life looks to him and says, "Why am I alive?" And the doctor doesn't care. It makes this new life rather miserable, and this new life goes on to destroy the doctor's life and everything that he held important. The doctor creates a problem that he cannot solve. Modern medicine has kind of a similar problem where we've broken down the body into constituent parts. Then we can analyze it deeper and go to genetics and go to biochemistry and all kinds of different levels of analysis, all to better understand disease and disease processes. Along the way, we've kind of lost sight of the purpose of healthcare, which is to take care of people who are not doing well. When people like this come to healthcare, what we do is we bring out an algorithm. And the algorithm will then show us how to address this person. And it's not the person per se, but the disease that they have that we're going to actually work on. Right? And so this algorithm then shows us if a person comes with this kind of a problem, this is what you do. If they come with that problem, this is what you do. Do these tests. If the results come out like this, it's that diagnosis. If the disease comes out like this, it's that diagnosis. And then we take that and we apply this algorithm to the person. So now we have a person who is fit through an algorithm, but it doesn't really cover them. It doesn't cover their needs, what they think is important. It takes out what we think is relevant and uses it to diagnose a disease. And as a result, we can save lives. We've done a wonderful job. There's more people alive than ever before. But we're not curing diseases all the time. And as a result of not curing diseases, people survive, but they might need long-term medications that can hurt them financially. It can make them ungrateful for all the things that we've done for them with the best of intentions, just because it's a whole new problem for them. The Frankenstein conundrum. Modern medicine has facilitated the emergence of a class of diseases that tests cannot detect and pills and surgery may not completely cure. These are often called functional diseases because there's no organic basis that we can detect for them. And as a result, people get sick and tired of the system of healthcare we promote, lifelong medications and treatments, and they go and seek unscientific care options. In the old days, healthcare was very much dogmatic. You find out the greatest mind of your time, you blindly repeat whatever they say, and you'll be safe. Whatever you say will be socially acceptable as a treatment, and you won't be questioned when you do what you have to do to help people. Now, in the modern age, we have evidence-based medicine where you can attack someone based on guidelines. Based on these guidelines, you didn't do the right thing. Based on the latest science, you're missing out on what you could have done. It's the same game in a different form, but it's a bit more refined. And it's not to make fun of evidence-based medicine. It's very useful, but it's very useful in a particular setting. Touch and go care, hyperacute care, procedural care. That's where it works the best. Where it doesn't work so well is with subacute or chronic care, when a person survives from all the other stuff and now has to go back to life, but isn't happy with what they've received as an outcome. And this is where we end up in magic crystals being used to heal people, fad diets, snake oil, and all kinds of shams and quackery proffered by people who may or may not mean well. But there's definitely something to be had in it because there's people who seek it. And when you tell a person they have to be on lifelong medications for their problems, they'll at some point refuse and they'll go like zombies from one thing to the next, looking for what they think is going to cure them and give them what they want. This is how we create a problem that we cannot solve. These people live, but they live in a way they're not happy with, and they're not happy with what we provide. So many different paradigms. And that different paradigm is going to be explained in view of what the normal paradigm So all healthcare begins with the person who has a problem. And from there, we do our history, our exam, our differential diagnosis, investigations, treatment, follow-up. And if the disease gets better, end of care. If they don't, maybe go and look for more diseases. If they don't get better and know the disease can be found, then we say, it's all in your head. It's probably psychological, not my headache. Go to a specialist. If you're the specialist will say, hey, not my headache, go away. Go to a psychologist. Now, that leaves people upset. And it's natural. Nobody wants to be treated that way. But the other part of the problem is we're missing out on what these people think is important. So because we haven't listened to what they've had to say about what they're going through, you have a person who has even bigger problems. And for that, we need a different kind of approach to address these kinds of issues, which starts with a history. So an example, as someone who's been treating pain patients for the past 17 years, there's a particular history we get. What is the nature of the pain? What is the characteristic? What is the radiation pattern? What makes it better? What makes it worse? And then we can say, okay, this is the type of pain you have. And then, okay, here's your pills. Take them, go home, and call me in the morning. That's what most doctors will do. Now, another level of exam and diagnosis will be when you come to a physiatrist and they'll say, look, what is causing the pain? What is that pain generator? Because only these kind of doctors, physiatrists, will have the tools to address what is a pain generator. But all this is addressing disease. It's not addressing the person with the problem. So we need to change things around. And we need to change it because of a particular type of patient, which is stereotypical, and I'm just going to use them as an example, but it's a 50-year-old lady, a little bit overweight, worn out from life. And when she comes in and says she has pain, we ask her, why do you have pain? And she says, my husband beat me in my neck 10 years ago. And every time that guy gets wild now, before he can do anything, I get a neck pain. That doesn't fit into our algorithms. There's no place for them. Most doctors would smirk at this history, ignore it, or just tell him, hey, it doesn't mean anything. You're perfectly fine. He hasn't done anything to you. Forget about it. But to this person, it's very important that this happened. And it's a concern that's going to be ongoing. So they don't want to deal with this and they want a cure for it, but it's manifesting as pain. What do you do? With neurotherapy, what we do is we take a history of life, and this is where that person can say whatever they want, whatever they think is causing these problems. They get to express whatever is important to them. Having done that, we do a physical exam, autonomic reflex testing, and then from there, there's no more special tests. This is literally Stone Age medicine. You listen to what the person has to say, you do a physical exam, and we localize areas that we think we have to treat. When we treat them, we see what happens. If they get better, then we've obviously found out the problematic areas. If they don't, maybe wait to retake the history of life or do testing again. And maybe follow up as needed. People at times can be like onions. They'll have multiple layers. So you examine them one time, you get one thing that improves. They come back with a different thing. You get another history of life, an exam, treat them, and maybe that goes away and they come back with something else. This is maintenance therapy, and it's okay. There's no problem. That's how this whole paradigm of healthcare works. What is neurotherapy? It is injecting local anesthetics in low concentrations at specific points of the nervous system with a therapeutic and diagnostic aim. Points are chosen according to the history of life of the person, all the events that led to them coming to you that day. And their aim is to regulate. Regulate what? The autonomic nervous system, that thing we learn in first year of medical school and conveniently ignore because it doesn't modify anything and we don't really have pills or surgeries for it. Why should we modulate the autonomic nervous system? Diseases don't just suddenly happen. They have a natural progression, a history of natural history of disease, in which the disease progresses if you don't interfere in what it does. Some diseases, they come, they go, they leave you alive. Some come, they stay forever and they go with you when you die. Others come and kill, right? Different types of diseases. And all our textbooks map these out. What is the natural course of the disease? Because as doctors, we're going to interfere. And when we start interfering, things really start to change. So you have to know what to expect when you interfere with it. We have a clear trajectory for diseases, but it's not linear. It's actually a lot of oscillation on it between different types of patients with different diseases or the same disease. There can be a great amount of variability. Some people will have all the best prognosticating factors, but they'll have a horrible outcome. Some people have everything bad, but somehow they'll just come through and shine and do well. And there's no predictability here, but this oscillation produces a lot of headaches for clinicians. With respect to trying to prognosticate and forecast and modify the treatment plan until the person can get back to doing what they were doing before. So how does neurotherapy work? Well, say you have your 50-year-old lady who gets pain before her husband hits her. Why is that happening? Most people would be inclined to say that's just psychological, but in fact, we all have to survive as humans, and survival means fight and flight. And that means storing memories of things that could be painful. So in her limbic system, she likely has a memory of this and how that guy got wild and what his behavior was like. And when he gets that behavior, the limbic system fires. Now, the limbic system fires and it activates the dorsal reticular activating system, which actually regulates the resting muscle tone throughout the body. So now your muscle tone is increased and it's going to irritate the tissues along those things, and that can make this pain. So how do we do neurotherapy? We're going to inject the otic ganglion, ciliary ganglion, stellate ganglion, pelvic plexus. We can inject periarterially, and we can inject into the fascia around the muscles and the tissues, facial interference zones. What is fascia? Fascia is a kind of tissue that holds the entire body together. It encloses and separates muscles and even attaches them and connects them to the internal organs. So when we inject the fascia, we're actually treating these things. And the fascia is innervated with the free terminals of the ANS, which acts as a synapse. Now, people say that's not true, but then we have continuity, which is validated by confocal laser endomicroscopy. So the body is connected to itself. It's not discrete little mutually exclusive systems. It all works together. Who needs neurotherapy? Anybody with an autonomic nervous system. Commonly, people who have diseases that are not responding as expected, except people with this disease, fibrodysplasia ossificans progressiva, which is really a strange disease. If you see this diagnosis, please don't put needles in these people. There's only 500 people in the world. One of them belongs to me. If you inject them, you'll have bone formation at the injection site, and you'll make that person's life miserable. When should we inject? Any time in the natural history of a disease is fine, but earlier is better. It's most appropriate for those with all tests normal with many complaints. What do we expect as outcomes? I'm going to be honest with you. I'm only going to show you my successes. The failures went on to be as they were. Nothing bad happened to them. Nothing really good happened either. But here's the people who succeeded. So here's a 16-year-old female with complex regional pain syndrome after a trivial incident 5 years ago, admitted in all the major hospitals of Kerala, under all the major departments, no change, came to pediatric neuro 2 years ago for neuropathic pain and inability to walk. Pediatric neuro said, hey, go to Revi, get some physio. So they come, they get a month of this, nothing changes. And the family says, is there anything else you can do? So I offered him neurotherapy. And you can see how she is before injection. Happy this is the patient I mentioned later. Her name is Anne-Marie. She has really bad RSV and CRPS. This is the one whose foot you saw earlier. I wanted to show you the skin before I plan to inject. That's an anterior view. Can you get some more light? So you can see the skin is black, it's tense, it's shiny. The knee is in a recurvatum with an equinus because the gastroc is so tight. And when she puts a fan on, the leg starts to hurt because there's neuropathic pain. She's slowly becoming more and more miserable because of this. This is her after injection. It is now June 2021. The last time we saw her was in March. In the interval, she's been at home studying. The leg overall appears better. The skin changes that were there before, as far as blackness and discoloration, are overall resolving. There is actually skin texture over the dorsum of the foot, which was not there before, is tight and shiny all this time. And can you move your foot for us, please? We have much more active dorsiflexion and toe extension. That's the problem area that we had detected before was the scar here, and that appears to be also better. Overall, the amount of pain she's having has reduced with the whole method. You can see here the knee is no longer in a recurvatum. She has active dorsiflexion. The skin is obviously better, and its normal texture is starting to come back. She's moved on in life, and she's doing quite well. Here's an amputee with complex regional pain syndrome. He's 25, and he was 1 year after a bomb blast which took off his fingers and thumbs on both hands. And he came to India, to our hospital, for a hand transplant. He was deemed to be not an appropriate surgical candidate, and he was referred to us for physiotherapy. Go to Ravi, get some physio. After a month and a half, there's no change. So he's asked for other options. And why? Because he can't sleep. He's having horrible neck and back pain, stump pain, etc. So I offered him neurotherapy. And after the first session, his cousin sister said, please don't inject him anymore. That was horrible. And we said, okay, fine. But after a week later, he came back and said, no, do it again. Whatever you did helped me so much. I need more of that. So that's what we did. This is him. This is Ali. He's from Yemen. He had an accident that affected his hands. How many years ago? 1 year. 1 year ago. You can see the residual stumps. He has undergone months of physical therapy. There is some improvement, but not much. The tissue texture is rather tight, especially along the scars. This looks a lot like complex regional pain syndrome. It disturbs his sleep. Then he's continuously suffering from neck and back pain as a result also. He came to us for a hand transplant, but they can't do much until the tissue improves. So they've sent him to me for basic care. With all the therapy service, not much has happened. He's not worse, but it's not resolved yet. So I'm going to do neurotherapy. You can see all the spots I marked. Please tell me what else I should be injecting. So you can see all the places I injected. This was horribly painful for him, and it would be with complex regional pain syndrome. Look at how tense and shiny and bloated those stumps are. This is him after treatment. This is Ali, and this is his newly gained wrist flexion. Stefan, thank you. You can see the tissue here has become quite supple. The styloid process is becoming prominent. And we can see the carpal bones emerging from as the edema goes away. You can see how much turgor we have in the tissue compared to just being fully non-elastic in the past. So he got better. Not only that, his pain went away to such an extent he could sleep. Him and his wife now have a baby. And it's never really ends here. I mean, we're rehab doctors, right? So there's still a whole set of things to do to get this guy to use his hands. And our plan was this, the Flexi Hand 2. You know, being 3D printed, we could scan his stumps and modify the hand for it. So we printed this mock-up to see if he'd like it. And in the interval, he went and got his hallux moved up to his stump. So he gained a thumb that way. And he was very happy with that. So he's gone back home and he's doing good. Here's a sad story of a 59-year-old lady with really bad pain. And she was referred for colostomy reversal after surgery, chemo, and radiation for rectal cancer. Now, the surgical oncologist was not confident to reverse the colostomy because she was having so much surgery site pain and fear. 100% pain, burning raw sensation on the pudendum, no specific aggravating or relieving factors, all over the pudendum, and it's best in the morning, worst at the end of the day, a surgeon not confident for reversal. He sent her to neurology for a sphincter EMG. Neurology knows I do pelvic floor, so they sent her to me. On exam, all over the pudendum, gluteal cleft, bilateral medial upper 1/3 thighs, pinprick is decreased, cotton sensation is decreased, and she screams and cries in the exam. Myofascial trigger points over the gluteal cleft, tissue texture is uniformly firm but not supple. So obviously pelvic floor dysfunction is not really a diagnosis you can work with, it's just a term. But we need to fine-tune the diagnosis here. So we started with myofascial pain syndrome with secondary peripheral sensitization, or radiation proctitis with viscerosomatic overlap. And we started treatment. She was referred for pelvic floor exercise, so that's what she got. And along with that, the pelvic floor nurse taught her an internal release with xylocaine jelly. And here she is at follow-up 1. She says she's better. The pain in the medial thighs is gone. Her pain ranges from 70 to 90%, and she's actively guarding her sphincter. On follow-up 2, 80% pain. The anterior pudendal pain at the labia is gone, but she's still having pain, and it ranges from 70 to 80%. Now, we're in a bit of a dilemma here. It's 2 months are over, and she's not making fast gains. So they could lose confidence in our ability to care for them or their own capacity to heal. And this can make them depressed, and that can make even more problems. So we're in a dilemma. Then I called the surgical oncologist and I told him, this is what's going on. If we discontinued therapeutic exercise and she failed, we would not be to blame because we're just doing what the guidelines say, but that's not fair to this person. So I told him this could be radiation necrosis in the rectum from all the radiation that she's received, mucositis, irritating the nerves in the rectum, which feed into the same place as the dermal nerves for the pudendum. To make that diagnosis, though, the surgical oncologist would have to do a scopy. And he said that's going to take a long time. The other thing I offered him was we could try neurotherapy. So he said, yeah, go try. Let's see if the injections work. Follow-up 3, after a month, she's much better. Her pain ranges from 30 to 50. We did another round of neurotherapy. And you can see here, the entire vagina is completely free of pain. It's just around the radiation site now. Follow-up 4, VS0 in all regions, and there's no more pain in the pudendum. She can contract her sphincter. So I called up the oncologist at Caritas, and I told him, hey, it's time for reversal. A year and a half later, she's doing perfectly fine. Here we have a 62-year-old male with urine incontinence after fall from a tree and landing on his tailbone. He has a conus medullaris lesion. He has an indwelling catheter for 6 months, which was then removed. He had difficulty in passing urine since then, and he has urinary urgency. He keeps putting in a catheter every 2 hours, even at night. And he comes on an indwelling catheter because he just got a UTI. So he came to urology, got diagnosis, got medications, went to neurology, got a diagnosis, got some more medications, went to neurosurgery, got a diagnosis, and he was sent to PMR for pelvic floor rehab. So we gave him a pelvic floor rehab plan. And after a month, he came back on an indwelling tube because he got a UTI and he was given laxatives. And this is where things get messy. So October 2020, new UTI, indwelling catheter, antibiotics. 2 weeks later, he's taken off and he's given more medications. November comes along, the same thing happens the next month. February, 3 months later, the same thing happens again. April, again, the same thing happens. And this is really just making him spend more and more money on medication. It's breaking him financially. June, August, November. So a year and a half passes this way. And with all this, this man is he's in the depths of despair. Is he ever going to do better? Is he going to spend his life like this on and off a tube? Is he going to suffer like this? And that's what his concern is. So he told me all this. I told him, look, I have neurotherapy. We can try it for you. He accepted. He received it. Here's urology's note for the next month. Significant improvement, able to hold urine for more than 4 hours. And they started cutting back on medications. His bladder volume was about 250 cc's, not that great. But when we come to PMR, we always ask a different history, and it's kind of on their quality of life because we're treating the person, not the disease. So he tells us that he has significant relief after the last neurotherapy, but he's upset. And why? He can't have an erection, he can't have an orgasm, and he's still constipated all the time. So he can hold urine for 3 to 4 hours now, whereas before he was leaking every 15 minutes, and we did neurotherapy round 2. Here's urology again. Bladder volume is improved, no fever, no dysuria, on tolterodine and baclofen. So they've cut down medications again, but they want him to keep those in few. And he comes to me and they're happy. He can get an erection. It's not a strong one, it's 50%. He can keep it up for about 5 minutes. He can ejaculate. For the wife, he ejaculates semen now, not urine like before. And that makes no sense to me, but they're happy. I'm happy for him. And he is on his intermittent catheterization every 6 hours and still has incomplete stool evacuation, but that's what you expect when you have an organic disease that's never going to heal. So those are some of the longer cases. Here's a short one. This guy's 55% hiccup for 1 week after a recent viral infection. He's on baclofen, cetirizine, metoclopramide, or ondansetron, all at max doses with no response, no sleep, medication side effects are full because he's on the highest doses. He has pain in his chest with cough and can't even get food down because he hiccups. We did a round of neurotherapy and he's symptom-free. Here's a 62-year-old lady from the Netherlands with dyspnea. Her cardiopulmonary workup was negative, and she says she has pain in her solar plexus for 1 year. Now, she has anxiety, mood issues, and poor sleep associated with this. So we did treat along those areas, and she has no more issues after 2 treatments. Here's a lady who is 44, has chronic migraines and cervical myofascial pain, 100%. The migraines are not controlled with medications. Neurology knows that we do neurotherapy, so they referred for this. And from the first session, her pain dropped by about 60%, but it was still a daily migraine. With the second session, she dropped to a 20% headache once a week. And she's not come for follow-up yet, but we'll probably get her a little bit better with further neurotherapy. You've seen a lot of the standard kind of cases, sometimes new stuff, but I think one of the most important things is, as practitioners, it's important to listen to what your patient says. And this patient taught me that. She's 24, from the Maldives, and chronic fatigue and pain. 100% pain, vomits 30 minutes after every meal, constipation, depression, 20 kg weight loss, seen in all the major departments, workup normal except for ultrasound, in which there's gallstones. So she's set up for surgery. Right now, I didn't know all this gallstone business. We did a round of neurotherapy. She said she felt better. She went home and came back for the second round a month later. When she came back, I was busy trying to figure out where we have to inject. And she kept talking about gallstones. So I'm examining, she says gallstones are better. I didn't really hear her, so she said it again. The third time she said it, I knew she was saying gallstones, so I asked her, what are you telling me about gallstones? And she said, before you treated me, I had gallstones. After the treatment, my vomiting reduced from every day, 30 minutes after a meal to once a week. So I was set for a gallstone surgery in my home place, but because I felt better, we got another ultrasound and there was no gallstones. I was a bit shocked at that. But nonetheless, with the subsequent neurotherapy, she continued to improve. She is no longer constipated, no longer vomiting at all. She's gaining weight. She is no longer fatigued. She works an 8-hour job and works hard. She's doing quite good in life. For all the times that we've done this neurotherapy, about 4 or 5 times now, I've always felt there was some kind of weight hanging over her. She went from completely dull-eyed and tired to having a sparkle in her eyes and a really nice smile, but you could see there was something bothering her. So every time she came out, I asked her, what's bothering you? And by the 5th time, I had to probe a little bit more, but she came on, she said, and she was kind of hesitant to say, but she said when she was in 2nd grade, someone did black magic on her. And because of that, she has an area in her low back that always starts off with problems, and all the other symptoms that she's experienced through her life come from there. Right. So we did a physical exam, and that actually showed that area was slightly different and behaving abnormally in relation to the normal tissues. We treated, she's better. If anything, I want you to do is listen to your patients. They might tell you weird things that don't fit our algorithms in modern medicine, but it's important to them. And do I know black magic enough to judge it? I don't know any of that. But I know I listened to the patient, we treated her, she's better. There aren't many physiatrists that do hyperacute work. We do it. And it's been a nightmare for the past 13 years because we get people with severe traumatic brain injuries who have autonomic dysfunction. So they can take their heart rate from 49 up to 150, 160, 180. They can suddenly stop it and die. And all these things become really difficult to manage these patients because no amount of propranolol, antipsychotics, trazodone, cooling, etc., will get them to stop doing these things until they finally wake up. But with neurotherapy, we've gotten control over these kind of symptoms too, along with the bruxism, where they keep grinding their teeth until the teeth break off and they aspirate. I don't have to worry about these things anymore because of neurotherapy. I want to start wrapping up here. If there's anything I want you to get out of this, is that no two cases are the same. Whatever term, whatever diagnosis we give them, no two people presenting with complaints are the same. History of life and autonomic reflex testing will always differ from patient to patient and within a patient from one exam to the other. As with all things that are not guideline approved and standard of care, there's always a doubt whether this is quackery or not. And much of quackery stands on the two legs of being the latest, the greatest, the super healing, the curing, the wonderful, spectacular, right? So is this such a thing? Is this the philosopher's stone that's going to save everybody? No. It is a tool to better address patient concerns, things that other doctors have ignored that's really important to a person. But it's still important for that person to be mindful, compassionate, be sensible in their behavior, But when they're not suffering, it's much easier to be mindful, compassionate, and commonsensical. The bottom line is we've created a system where people are going to live, but they may not be exactly happy with all their outcomes. So when a cure is not possible, the role of healthcare is to comfort people. We are nothing without our teachers. This is Dr. David Vines, MD Family Medicine, and his student, my very first teacher for neurotherapy, Katia Puente Costa de la Vega, and also family medicine. They are both based in Barcelona, Spain. This is the certification course in October at LaGuardia last year, 2022. It was a lot of fun. It's not one person doing wonderful things alone. There's always a team. I have a nurse that helps me with all these different things. And a wonderful department full of people who work hard every single day, making sure patients get the best possible outcomes. Thank you.